Hello everyone, welcome at Sudhir Eye Coach. Today I'll be sharing a video where I handled the zonular weakness, which was a surprise during a normal looking cataract. As usual, I created the side port incisions. I continued my capsular access. Then I created 2.2 millimeter clear corneal incision. Did a fair amount of hydrodissection. At this stage, everything was appearing normal and the nucleus was hardly grade 3, grade 4. Everything was going fine and it was normal appearing cataract. I started phaco-fragmentation. Normally I do vertical chop. I held the nucleus and divided the nucleus in two pieces, then gradually picked up pieces and started phaco-fragmentation. Till this stage everything appeared normal, but suddenly I realized that something has happened in the antechamber. Suddenly the chamber became deepened and I withdrawn, and in the anticipation that something has happened to the posterior capsule. So I filled the antechamber and then gradually I rotated the nucleus, because in the cases of posterior capsule rent, the rotation of nucleus become difficult. Since the manipulation was normal, but what I did that I reduced the intraoperative pressure, and with the reduced pressure I started phaco-fragmentation again. I held the piece and divided it in the pieces, and gradually with the low pressure settings I continued phaco-fragmentation. However, the surgery was proceeding as I expected. Last few fragments, and with the low pressure settings I removed the last piece and withdrawn the hand piece. As I withdrawn, I realize the surprise is in front of me. I saw a capsular bag dehiscence. So I filled the antechamber and bag with the viscoelastic and assessed that is there any vitreous forward vitreous movement. Since the dehiscence was limited in a smaller area, I thought to continue the cortical cleanup. Many thoughts were coming in my mind, whether to put a CTR to support the bag or keep the eye tip away from the area of dehiscence not to catch hold the vitreous. I keep on injecting viscoelastic to retain the bag in the place, and luckily the cortical matter was limited and it was there in the area where the capsule support was fair and strong. So with the lower uh, pressure settings, I continued to remove the cortical matter. I am an old generation phaco surgeon and more comfortable with the coaxial IA. Removing cortex from the subincisional area is always tricky with the coaxial. I made reasonable efforts to remove the cortex, whatever cortex I can remove. Then I filled again the chamber with the viscoelastic. Then I decided to implant the intraocular lens, and with the tensile strength of the IOL, we can stabilize the bag. That was the thought which came in my mind. So I implanted single piece hydrophobic implant and injected in the bag, and I kept the IOL in place where the dehiscence is there, so that the haptics can give strength to the dehiscence area. I knew that I'll go very near to the dehiscence area, and if I'll try to remove the cortex which is there, I can catch hold the vitreous track, and it happened. Eye tip dragged vitreous strand, but fortunately there was not much of vitreous movement forward. Then I removed the cortex which was there in the subincisional area. You can see the vitreous strands coming to the eye tip. Irrigated the chamber with the miotics so that I can see the shape of pupil, because that is the first clue to get an idea about the vitreous strands present in the antechamber or reaching to the incisional area. Fortunately, there was no vitreous present in the antechamber. There was no need for vitrectomy. Finally, I performed the surgery well, but I knew that this was not the the decent way to handle the situation. It was always better to put a CTR as you get the decency, and in that way you can manage the case well. Thank you for watching.